Colleagues, very welcome tonight to our first SAI Eastern Cape chapter webinar. We are privileged to have you with us tonight as our audience. I am the elected chair of the SAI Eastern Cape chapter at this stage, and therefore it's my privilege tonight to welcome all of you and also to welcome our speaker for tonight. If I move to the next slide, just very briefly, for those of you who are not familiar yet with SAI, SAI is the Southern African Association of Health Educationalists. The website is on the screen, and if you're not yet familiar with SAI, please visit the website because there's a lot of information on it, and you will see the different chapters. You will also see the special interest groups, and then there's also resources and information about the upcoming conference. The SAI vision and mission statement, quality and resilient South African health sciences educators as leaders for Vision 2030. You can also read this document on the SAI website. It is important, if you're not yet familiar with SAI, to see the background and also what SAI stands for. I think the idea is that we are all one family in health education in Southern Africa. We want to meet each other, we want to talk to each other, and we want to learn from each other. What SAI stands for, and it is an association of health sciences educators from universities, NGOs, and government and private sector. The focus is on improving the quality of teaching and learning in health sciences education to enhance the delivery of high quality, affordable, and sustainable healthcare to South Africans and other Africans in both the public and private sector. And then being a SAI member means that you are committed to improve teaching and learning in medical and health professional education. We are from a variety of health disciplines, medicine, but also we've got pharmacists, we've got occupational therapists, nurses, the whole spectrum of people involved in health education are welcome to be members of SAI. SAI showcase the best practice in health science education to stimulate debate, very importantly, and discussion regarding the education of health practitioners, to develop teaching and educational research capacity in health sciences educators. The organogram for SAI. So we've got a national exco consisting of a president. Currently our president is Professor Elise Archer from Stellenbosch University. Our previous president was Professor Francois from UCT, Francois Sillier. We've got the vice president, the secretary, and the treasurer. Then we've got our council chapter with the different portfolios, and then regional chapters. And this is where we are coming in now as the newly established Eastern Cape regional chapter of SAI, and then we've got SAI membership. SAI membership at this stage, 200 Rand per year. If you join the conference or attend the conference this year, your membership fee is included in your registration fee. Conference is next month. Organized this year by University KwaZulu-Natal. Last year it was here with us in the Eastern Cape. So we have decided in November last year to start our SAI Eastern Cape chapter formally, and this was our agenda for our meeting towards the middle of November. And we had Professor Archer giving us a short presidential address. Then we reported back on the under 40 group that we tried to establish during the conference. We were talking about reflecting back on the conference, and then obviously we started to formalize our local committee. So colleagues, tonight we present to you then our SAI Eastern Cape Committee. At the moment I'm the chair. I've been part of SAI for many years, far more than 10 years. On and off on the exco of SAI. Passionate about health education, although definitely not an expert. Then we've got in alphabetical order Professor Sue Burton from Rhodes University, Ms. Sharnae Christians from Fort Hare University, Dr. Mulder tonight. Thank you very much from Walter Sisulu University, who is our first speaker. And then Dr. Rian van der Venter, Nelson Mandela University, Prof. Talena van Rooyen, also Nelson Mandela, and then Mrs. Rosanna Williams, who was the conference chair last year for the conference, local here with us. She is also on our committee, 7 members. This is an extract from the SAI Constitution, and you can see all 4 universities are involved. And then also for tonight, we have invited wider than only our 4 universities. The next webinar, the title of the topic is Game-Based Learning, and Dr. Rian van der Venter and team will take the lead on that, and that will be early in next semester. We will announce the exact date very soon to you, so please be on the lookout for that. My privilege tonight is to introduce Dr. Madeleine Miller to you. For those of you who do not yet know her, she's a family physician, senior lecturer at Walter Sisulu University. She's convener for the CMSA Diploma in HIV Management and serves on the CMSA Senate Examinations and Credentials Committee and the College of Family Physicians Council. She's also on the RUDASA Executive Committee. And you can read Dr. Miller. It is impressive. I'm not going to read every. You can also look on the website for the bios of the different committee members, and Dr. Miller's full bio is also on the website under our chapter. Currently, Dr. Miller got enrolled for your MPhil in a degree in health professional education through Stellenbosch University. And then you are passionate about inclusive clinical care, sexual and gender health, teaching curriculum development, supporting the growth of patient-centered clinicians. Tonight, we are privileged to have you talking to us about a topic that I know you are passionate about and very knowledgeable about, and that you are a leading expert in the field, in the medical profession in South Africa. But us, I'm a pharmacist by training. We're also radiographers. We are from a variety of disciplines. Tonight in the audience, work-based learning and work-based assessment are important to all of us as health educators. So Dr. Miller, we are looking forward to listen to you. Thank you very much for leading us into our series of webinars. The plan is, colleagues, for us to have every year 4 webinars, 1 every quarter, and to have a variety of topics from the different universities, from different health professions, topics that are relevant, that are topical and of interest, and that we together we will learn and become stronger in health education. Thank you very much, Dr. Miller. I'm going to stop sharing and I'm handing over to you.
Thank you very much for that introduction. It's very lovely to be here. I've got a huge love for the whole educational field. And so to actually be able to have a platform where we can literally just talk about education and teaching. And I think one of the things that we're really going to focus on this evening is in terms of our skill in training and teaching and assessing the many young doctors and clinicians that come through our departments. And the reality is that teaching is pretty much part of, I think, almost every single clinician, especially if you're in the public sector. You are always in scenarios where you teach. Even if you don't have registrars under you, there'll be interns coming through, there'll be new junior doctors, there'll be younger staff members, as well as our support of colleagues. And work-based placed assessment, which we're going to talk a lot about tonight, is a little bit of how we're starting to look at actually how do we skill up us as doctors in terms of teaching and assessing in the workplace. So we're already doing this job, but actually we've not had much training or haven't had much experience in terms of the academic side of education. So we're gonna focus on all of that this evening. So what I'm basically going to be covering is I'm going to be doing a lot of concepts. So for those of you very familiar with WBA, just bear with me. We're going to go through all the definitions and the terminologies and what it all means. And then we're going to look specifically within the context of South Africa, what is happening. I'm going to tell you about the Upwork study, which is a WBA study that's taking place at all 9 universities and also here in the Eastern Cape. And I'm hoping we'll have enough time to just have a couple of actual educational slides on feedback. When we talk work-based assessment, feedback is probably one of the most important skills that forms part of that. And so I would love to have a couple of slides on that for you to take away into your working space tomorrow. So we sort of bandy the word WBA around quite a lot, but WBA is actually part of a wider concept or a wider paradigm shift within the world of education, and that is what we call competency-based medical education. So if you go and look up in terms of what is happening also internationally and globally, in education, in all of the health professions, this is what will come up. We are moving towards competency-based medical education. And competency-based medical education has got 5 major components. Firstly, it's based around competencies. So what do we expect people to be able to do? So it's very much built into the activity side of things. We want people to sequentially get better and better at all these competencies until they reach a point where they now actually have the full set of competencies they need for whatever they're studying. To be able to get those competencies, we will create tailored learning experiences, so depending where you're at. So quite often when we're training professionals, they will already have had various experiences in the past. And so instead of having just a standardized course, you're actually working towards helping that particular person achieve those competencies. When we instruct, we actually teach people how to do stuff. We don't focus on the knowledge side. And the assessment, therefore, looks at the whole programmatic assessment, includes all of this competency component. So that's just a very broad, boring, basic outline. And the reason why the world is moving towards this, there's actually quite a lot written about why we should move towards competency-based education. And there's 4 major points that I'm picking out from an article written by Nell in 2022, where they're actually showing the vision of what we're going to be doing for competency-based medical education in South Africa. And probably the biggest thing is around accountability. So the public has basically asked us as healthcare professionals, when you say that person is now a specialist or a doctor or have got their diploma, how sure are you that they are competent? And that's quite a big question. So quite often you might have a registrar who has now been under your care for 4 years, and now they go off and they write some big fancy exam at the college. And how sure are you that that person can step into practice and can be entrusted to be competent in all aspects of that particular specialization, for example? So we need to be accountable for what we do. Competency-based has got a very big emphasis on skills and attitude. So rather than knowledge and all the stuff we're expecting people to know, which is so easy to measure in exams, we actually now want to know is, can they do the job? Can they do it well? And can they do it in a professional manner? This also makes it possible that although I think we'll still probably stay very much with our sort of basic timelines, but it does free it up, that rather than saying, okay, all of this you cover in this particular year, and then in your next year you cover all of this stuff, you're much more now focusing on saying you will qualify once you're competent. And we're working towards you gaining the competencies rather than just getting you through a particular time period. And then because we're working on competencies, we now build a very clear path. So we say to the learner, this is the competencies you want to know. And the idea is now, how do we guide them towards getting those competencies? And this makes it a very practical way of educating. So out of the literature as well, they have shown that WBA and competency-based medical education definitely enhances patient safety. So we actually create safer doctors. But it's also very helpful for what we often call the registrar at risk. So everybody, when they go through a training situation, everybody's different. Sometimes people go through particularly difficulties, which actually affects their training. Some people are maybe having certain skills that they are struggling with. And what you don't want to do is somebody to go through a whole 4 years of training. And now you get to the point you go, oh, well, hey, maybe you shouldn't have picked a surgical direction, really. What we want to be able to do is have enough data points to give somebody feedback on the areas where they're struggling and to pick up those problems early on and either moderate those problems, help the registrar get to the competencies they want to be, or maybe even send them in a more appropriate direction in terms of their future development. So this makes it possible for us to not just wait for that final exam at the end of the 4 years to decide whether somebody is competent or not. So this is the history of what's been happening in South Africa. And I'm just going to go through this timeline. So here on the left, in March of 2022, based on all this international evidence, the Committee of Medical Deans, so that's the 9 universities, that's the medical schools, particularly the medical trainings, together with the colleges of medicine, who does all our exit exams for us, they formed a committee together and they made this decision that we need to establish WBA as a key part or assessment method as part of our postgraduate trainings. So this is particularly looking at all of our registrars in South Africa. So situational analysis was done in October 2022. I will report back a little bit on that later. And so in March 2023, they started rolling out EPA workshops at all of the, by now it's all 9 faculties have had these workshops. And I'm going to teach you all about what we mean by EPAs. And then in September 2023, they launched a study. So that's the OpWork study. We've been getting ethics approval at the 9 different universities. We've just got the WUSU ethics approval for WBA literally last week. And so I will be telling you about the study in terms of us looking at what is the feasibility of doing WBA in South Africa and in our universities. We'll be reporting back on our progress on that at the June 2024 conference, which is next June. And the idea is that we'll actually be publishing, there's the word, a national WBA guideline specifically for the South African setting. So there's all this lovely things going on globally, but actually how we're going to do it in the South African setting. And the Department of Higher Education and Training has actually given us some money, a grant, to particularly help with the training of consultants and registrars in this process. So let's just dive into all these different terms: EPAs, WBAs, CCCs, all these wonderful new abbreviations. And when you want to think in terms of competency-based medical education, I want you to think of sort of 3 major steps, if you can think of it like that. So firstly, you need to create a curriculum, and that's where we're going to talk about EPAs. Then you need to make multiple observations over the 4 years based on that curriculum. And this is very much this workplace observations. You can see I'm not even using the word assessment there. They are formative. So they're all about giving high quality feedback as you go along to help somebody reach all those competencies. And a big part of the component is having all these millions and millions, well, hopefully millions, hundreds of data points over the whole training, with a lot of little low-stake assessments, lots of different scenarios, lots of little assessors. And within the world of validity, we are thinking in terms of saturation, triangulation, and aggregation. And what those big words basically means is that although one small assessment like that cannot possibly tell you whether somebody is competent, but if you've got lots of assessments out of lots of different places by lots of different people, that will actually give you some very good data in whether somebody is actually competent in a specific area. So the language that we use for our curriculum is around EPAs and milestones. So EPAs has got to do with curriculum building. Then we have the actual workplace-based assessments that are going to be happening during the 4 years based on that curriculum. We're going to be recording all of that in an ePortfolio. And then the decisions in terms of progression is going to be made through something called clinical competency committees. The name also is still a little bit in debate. And I'm going to go through each of these components now in more detail. So let's start with EPAs. So EPAs stands for entrustable professional activities. And the word entrustable is not even in the dictionary yet. It's a word that particularly belongs to the world of WBA. And the EPA is a unit of work. So it's an activity, and it's an activity that you would expect somebody in that discipline to be able to take responsibility for. This is what you do. So if you think in terms of a particular discipline like obstetrics or anesthetics or family medicine, I'm using those 3 examples because we are the first ones to be implementing it here at WUSU. And that describes sort of the full disciplinary scope, all those EPAs for that particular profession. So once you've described all your EPAs, you're actually able to say, when this family physician finishes, this is what they will be able to do. So it literally describes the full scope of your practice. And the recommendation is, when we're now creating our EPAs, that there should be about 20 to 40 EPAs for a whole speciality. So any area that you're going to be splitting up into these activities, do keep them relatively manageable. Each of the different colleges, so the colleges of family medicine, colleges of surgeons, colleges of obstetricians, colleges of pediatrics, etc., is each going to be responsible for developing that disciplinary scope for each particular discipline. So what's already happening is the universities are coming together. So in family medicine, we had representatives from all the universities that created a working group, and together we've created the EPAs for family medicine. I'll show you what those look like in a minute. I know the obstetricians are very far along with creating EPAs for their particular college. I know the pediatric surgeons are busy with the EPAs at the moment, the emergency medicine guys, the anesthetists. So this work is already happening, and there's already people involved in creating it. And what will happen, therefore, is there'll be one standard set of description of what we expect an obstetrician will be able to do, no matter whether they're finishing at WUSU or UCT or WITS. Those EPAs are going to be exactly the same. Where the variety will come in is how each university is going to help their registrars to get to that particular disciplinary scope. So each training program, we at WUSU will take those 22 EPAs and we will create our own training program on how we're going to help our registrars achieve those 22 EPAs built on our own context. So this just shows you what we as family medicine guys came up with. You can note that those EPAs are written very much with those infinitive verbs there, those active verbs, because they're all activities. You can see we've got 22, most of them very clinically, practically based. But for family medicine, we also have at the bottom here providing training, leading a clinical team, leading clinical governance activities, for example. And what we've been doing as the colleges together, as a college and as universities together, is we've been describing in detail what we mean by each of these EPAs. So, for example, we have EPA number 2 is about managing pregnant women, and we would then describe what is included within that EPA, and then there'll be a detailed knowledge, skills, and attitudes specifically for managing pregnant women. Here's one on anesthetics, for example. What exactly do we expect a family physician to be able to do from an anesthetics point of view by the time that they are qualified? So once you've defined that and described that, and you have that vision of where we want our registrars to get to, we now want to help them get there. And very important is that, and actually there's quite a bit of debate about whether we should even call it workplace-based assessment, and rather just use the word workplace-based observations, because the focus of these assessments is not about progression. The focus of assessment is helping somebody improve over time in these different competencies and activities. What's sometimes, well, quite often we think of WBA as being this brand new thing, but actually this is what we're all doing all the time. So if you've got registrars or you've got junior clinicians that you are looking after, every single day you make decisions and we informally assess our juniors. So say, for example, you're an obstetrician and you've got a new registrars, and you need to decide at which point on call are you going to let them do that call without you present, and they can do cesarean sections as the lead surgeon, for example. So what you're actually doing is you're making a decision, and we're going to talk about entrustment or trust in a minute. Can I trust this guy to be in that theater on their own, or do I need to be in the theater? Would I like to be next door to the theater? Can I be at home when they do it? And you're actually making a decision already. You already make an assessment by watching them work, by seeing how they are performing in the workplace, on what level of supervision they need for a specific activity. So what work-based assessment does is it's starting to formalize that. And very importantly is it includes now formal opportunities. We are basically going to create a structure to ensure that supervisors are not only making these informal assessments, but actually feeding back to the registrar. So if you're thinking to yourself, oh, no, I think I still need to be there when they're doing that cesarean section, you need to have the opportunity to explain to the registrar what they would still need to develop for you to get to the point to trust them to be able to do that on their own. So the workplace assessment validity, therefore, to make this a valid tool as part of our long-term assessment means that we need to be able to be doing these assessments or observing these assessments using standard tools, and we'll talk about the tools in a minute. We want to build into these workplace assessments reflections. So for our registrars really being able to notice what can I do and what am I not sure about yet, and us being able to give feedback for the registrars therefore on where to go forward. So to make this more reliable as a tool is having these multiple biopsies over time. So we're always a little bit nervous about having one HOD that signs off the registrar at the end of the 4 years to say, okay, you're ready, you can go and write your exams. What will now happen is that a registrar is actually exposed to lots of different people over the 4 years. And many of those, senior medical officers, supervisors, even non-medical staff might be in some ways involved in actually giving feedback and doing these little work-based assessments. And by having lots of input from lots of different people, that improves the reliability of this assessment method. So what are we observing? So we have, our EPAs are telling us what we need to look at, right? So I've got that EPA, for example, for family medicine on pregnant women, and that's going to include, they have to be able to do cesarean sections. So my observations can include various things on that EPA. So I can either observe consultations, I can observe them consulting in an antenatal clinic, or I can observe their when they come and present a patient to me, which is more often. We don't really have time to go and sit in offices. We might observe a procedure, or we might even get feedback from other colleagues who are in the theatre on how a procedure was going. We might do an observation of the clinical notes that registrar has been writing, or we might observe them when they're doing a presentation in a CPD meeting or in a journal club, etc., etc. What's lovely about when we are observing is you're observing the whole full thing. So you're able to observe their knowledge competency. Do they know about this topic? You're able to observe their skill level. How good are they at doing this consultation or this particular procedure? But you can also observe their professional behavior and actually give feedback on that. So what was their manner like in breaking bad news to that patient? How did they manage that resus team with a resus that wasn't successful? And how did they manage the team afterwards? What is their communication skills like? So it also gives us the opportunity to give feedback on those so-called soft skills, I know, terrible term, from early on for registrars who might be struggling with some of those skills. So there's always a little bit of nervousness, and one of the complaints that sometimes comes up is the worry about standardization. So, of course, if we are all doing our own little bits of work-based assessments with lots of different supervisors, every single university, as a matter of fact, every single facility, it's going to be looking very different. And I think it's probably helpful to remember that at the moment, standardization is not happening. Even in here in the Eastern Cape and Frere and CMH, if you're in obstetrics and gynecology at Frere or you're obstetrics and gynecology in CMH, your workplace experience is going to be very different. You're going to have different types of patients, different types of working environment, different types of colleagues. No encounters or contexts are ever the same. And to try and standardize that has actually been part of the challenge of the old-fashioned trainings, which tries to have this very set way and how we're hoping to make it all the same for all registrars. So that's not applicable in real life. And WBA actually brings the solution to that. Because now what we're benchmarking, instead of trying to create a similar experience for everybody, we benchmark on this professional activities. So as a discipline, you have decided, this is what I want to be able to trust my newly qualified obstetrician or family physician or anesthetist with when they qualify. And it's that trust in that registrar, it's whether that person is competent in those particular activities that drives your training and your decision-making at the end of the training. So it doesn't matter how you get there. Every single facility can find their own routes and how they actually get to that particular point, but we are benchmarking on those professional activities. So one of the key components of all of this competency-based medical education is recording all of these decisions. So I've already mentioned that informally we are making decisions all the time about how much we can trust our registrar in a particular aspect or area, but we're not recording these, and we're not always very good at making an actual decision in terms of feedback and what needs to happen next. So there's unanimous agreeal that what we're going to end up with is ePortfolios. So certainly in the end, we want to be able to have easy to use technology available on every smartphone, where the registrar and the supervisor can capture every one of these assessments. So over this whole 4 years, you'll end up having this massive portfolio. And what's lovely with the tech platforms is it can then easily organize that information to help you keep track of what's going on in comparison to the old books. And when you make an observation, you're going to link it to those specific EPAs. So if they're doing a cesarean section, when you're doing you will link it to EPA number 2 if you're in family medicine. If you're in obstetrics, you will have a specific section that talks to cesarean section. And then you're therefore able to look at an EPA and be able to see where somebody has been, where their strengths are and where there's areas that still need to be recorded. The ePortfolio can capture just some activities. For example, they attended a CPD session or they attended an ESMO-E. But some of the activities is actually going to be properly assessed, and we're going to be signed off by a senior or a supervisor using something called entrustment. So we are moving away from marks, obviously, in this particular observations, and we are moving away from going with a competency or not competent. Then we had the not yet competent. What we're now looking at is simply in terms of levels of supervision. And this is what it looks like. So this is the language we're going to have to get very used to. It's called an entrustment decision. It's very different to us doing an exam or assessment to look at what the person already knows. And you can see here there are 5 levels. In some of the forms, we don't even write the numbers down. That's how allergic we are to any sort of classification. But certainly at the end of your EPA, you will actually give them an entrustment level that you would want them to achieve. So level 1 is they can observe only. So if it's a theater scenario, again, for surgery, they can watch but not touch. Number 2, they can do the procedure, but somebody needs to be there assisting them and watching them. Number 3, they can do the procedure, but I might be next door and can be called at any time if help is needed. Number 4, I'm happy to be for them to be on call on their own and do that particular procedure, and I can happy to call them over the phone if need to be. And number 5, now they're actually able to supervise others and they're actually able to teach others. So what's interesting about entrustment decisions, and what I really like about entrustment decisions, is it's forward-looking. It's not about, oh, how well did I think they did that? It's about being able to do, okay, how well do I think I can trust them to do this in the future from everything that I have observed? It's very good from a patient safety point of view, because you're really deciding not just, well, okay, I think he did that cesarean section really well. Oh, but it was a really easy one, but that's fine. We can tick him off on that. But actually, what happens if he has a cesarean section where something goes wrong, for example? It's very much about observations. It's not just something that you sort of look at the logbook and you go, okay, he's done 50 cesarean sections, I'm going to sign him off on that. You must have at some point at least observed, or have had somebody in theatre observe their capability. And it gives us this possibility to also look at things like professional behavior, which is a lovely addition. And I think what's great with the entrustment is that it understands therefore the limitations. You're able to say to somebody, okay, I can limit you to doing this with somebody assisting you, or I can limit you to doing this as long as it's during the day and there's somebody in the theatre next door. And it takes into account what you can expect of your registrar. This is just a fun little description. Of course, this is from the anaesthetists, where they created it's actually a very much more detailed, written out entrustment. And I think this is such a lovely reflection of what we automatically do. So when you are, for example, we're looking at a surgical These are all informal levels of entrustment, you know, so I'm not actually comfortable about leaving the operating room. Okay, maybe I'll pop out for some coffee. Okay, I think I can actually take some lunch. I have to check in regularly. I can wait till they call me. I can limit to just checking everything's okay and then going off. I don't even have to be on site, and this person is a consultant. And you can see we've divided, those are actually encapsulated in those 5 entrustment levels that we are using. So let's just look at the actual tools. So great. So now you're going to have a scenario. You're going to do an observation. You're the supervisor and the registrar. And family medicine, we've managed to create a multitude of tools. Personally, I think we might have created a few too many tools. We've got something called the mini CEX, which is a tool that we fill in when we're observing a consultation or a part of a consultation. There's the DOPS, which is observation of a procedure, and it can be used for any procedure. There's a case discussion tool. We call it an entrustment-based decision tool. So the registrar presents a case. And say, for example, they present a case on drug-induced liver injury. I might ask some extra questions to try and test their knowledge and how they would also manage that patient in more different or complicated scenarios. And then in the end, I can actually sign them. I can have an entrustment level for that particular topic. There's the 360 tools, which some of you might know. That's when you get your nurses, your rehab team, your managers, to like lots of different people to give feedback for you. And then you can also have tools where you're actually assessing, for example, a file or a particular practice tool. So what has happened with now is that all of us that are busy playing with EPAs and starting to look at observation are starting to play with tools. So what actually happens? We obviously have to record some sort of decision that was made during the observation, and we want to record our feedback that we've given during the observation. So what's happened is family medicine has taken a whole lot of these tools, and we are actually piloting a portfolio, an ePortfolio, where we are capturing all of these. It's called SCORI, and I'll show you a little example out of that in a minute. But some of the other departments, especially the more practical departments like Ops and Gynae and surgery, they've opted for a single generic tool that they can be used to actually capture that information. And there is an app, and I'll show you in a moment actually what the tool looks like. So under this under this national committee made up by the deans and the colleges, and with that little bit of money, they do have a tech team that's developing tech to help departments who want to do work-based observations. They're funding most of it, but they need a little bit of help with the running cost. So for example, a department can get Daniel Null and his team to develop you an app to capture your particular work-based observations. And that's a current cost of $1,500 that has to be carried by that department. So just to show you very briefly what family medicine is doing. So we're doing the Mercedes-Benz version, where we have like millions of different forms. Actually, it's 14 different forms. And the SCORI on ePortfolio works very well on the phone. Both the registrar and the supervisors got access to it. This is the registrar then has like a dashboard like this. And you can see on the left there, it will tell you, these are we did an observation, we did a mini CX, we watched a teaching session, and then there will be input on the feedback, what was suggested, what did they do well, and what could they have done better. And then on a different dashboard, you can actually look at each of your EPAs. Where am I with EPA 1 in terms of all my observations? So this is very, very hot off the press. So Prof. Adam, so that is obstetrics and gynecology from University of Pretoria. She's looking specifically after the EPA rollout in the different colleges. So they've been quite far in starting to look at what tool do they use to capture one of these work-based observations. And again, I like that word, observation competency tool. We don't want to put too much emphasis on the assessment part. It's much more about the feedback development part that's important. So this is what the app looks like in a paper-based tool form. So we've created a paper-based tool just to use for training purposes and to get people a little bit used to the tool and to be able to adapt the tool for their department. And then if it's a tool that works well for you, then one can get Daniel, Nell, and them to actually turn it into an app so that is available. And you can see it's very easy. So at the top here, you just got the registrar, the day of the observation that's happening. The Obs and Gynae guides have chosen these particular activities. So you might be in a clinic, you might be doing an operation, you might be doing an ultrasound. Then you briefly describe. So you can literally, it's very generic. You can put any activity in here that was observed, whether it's a consultation or a procedure or a teaching or whatever. You can decide how difficult was it in comparison with a normal activity. It was, so if it was a cesarean section, that was an array to cesarean section. Okay, that was slightly more difficult than usual. Okay, that was much more difficult. Then you actually describe a little bit how it went. And then we've got those 5 levels. Remember, we talked about the entrustment. So in the future, I've now watched them do the cesarean section, or I assisted them with the cesarean section. This is what actually happened. And this is what I think they can do in the future in terms of cesarean sections. The bottom part of the page for me is almost the most important, and there's a page then to give feedback. And the feedback is always very similar. You always talk about an aspect that went really well. Registrars don't always know what they do well. So this is not just the feedback sandwich, as they call it. This is actually about explaining to somebody what went well, then give a suggestion of something that could be done differently, obviously, and then having a very particular action plan. So if they're not yet to a level 4, for example, entrustment-wise, you want to help your registrar with a plan on how they're going to get there. So the next concept then is milestones for EPAs, and that means that you've now got these 22 EPAs, and as a training organization, you now have to decide when during the 4 years do you want them to be competent in which EPAs. So obviously things get more and more complex over time. So you might say for EPA 2, managing pregnant women, I want them to be on a level 3 by the time they're at the end of their 2nd year, for example. The progress that you are documenting, again, is that entrustment. It's not a pass or fail. And then at the end, you have a certification of trust for that EPA. So you have all these little observations, and in the end, you're going to sign off that EPA and say, okay, this registrar for EPA number 2 is I entrust this to a level 4, and he can therefore go and write his final exams. So who makes that decisions, and how do we put that all together? So the idea is that you're not obviously going to assess all 22 EPAs in the 1st year, and also you're not necessarily going to assess them all in the 4th year. You're probably going to build it up as the years go past. So there's some EPAs that the registrar might already be competent on in the 1st year, for example. So you'll have a certain amount of decisions that will get made. You're going to use all your millions of little observations to make the decision. And when they are competent in that specific EPA, I don't know who came up with this acronym, but I'm impressed. It's called a Statement of Awarded Responsibility, or a STAR. Cool. So they get a star for their EPA. And that means we've signed off that EPA, and we say they are competent in that particular professional activity. And so, of course, the goal is that by the time your registrar reaches the end of the 4 years, they have to be have stars in all 22 or 25 or however many EPAs you have. And then they can go and write their final college exams. So the assessment package, it's not that we're going to replace our current end of 4-year exam suddenly with work-based assessment. So the workplace authentic lived experience is just capturing that professional opinions and demonstrating those procedural skills. So instead of now having your registrar tested at the end in a focused OSCE for maybe 8 or 10 of his practical surgical skills, you're now going to be able to observe all of those over that 4 years, including professional behavior. And then you will still have your proper exams. So if you are a field with a lot of knowledge, like internal medicine, they're going to still have very heavy duty knowledge exams and application of knowledge for case studies, etc. at the end. There's going to be then a structured assessment of that decision making to determine how well is that knowledge applied. So you can still have your oral exams, for example. You might still have some OSCEs. I know from a family medicine point of view, we like the idea that our focused OSCEs will eventually be replaced by work-based assessment. And we'll probably have orals to look at decision-making, just as in terms of looking at that decision-making skill in our registrars. And we will still have some knowledge exams. So to help us pull all of this together in terms of assessment, we will have something called clinical competency committees. So again, instead of just having that HOD that signs off at the end of the 4 years, you now have a competency committee, and the big difference with this is that these competency committees sits every 6 months throughout the 4 years. And the idea is that it gives a possibility to help the registrar figure out where they are at with which EPA. So every 6 months, you meet the supervisor will meet with his registrar. You're going to look together at your EPAs. You're going to give them feedback on areas and make action plans of where they need to go. And you will then sit as a small CCC, you will sit and make a decision, okay, this registrar is on track, or actually this registrar is going to need some extra work. Maybe we should build this in, or maybe we should do that, or maybe you should go work in this department for a bit or whatever. When it gets towards the end of the 4 years, then there's going to be a national CCC committee that will look at all this evidence that the local committees have built up. So you will have all this portfolios and all this evidence. This evidence will then be submitted to the national committee at the end of the 4 years of the registrar, and they will then make the summative decision to say, okay, you can go and write your college exams. Good. So that's been lots of concepts. If there's lots of questions buzzing around, please feel free to put them in the chat so if you don't forget them, and we will have time at the end for questions and discussions. I know I'm covering a lot of theory here. I do want to give a little bit of a vision of now we've got all this grand ideas, what's happening in South Africa. And actually there was a situational analysis done in May of 2022. There was a call to let's actually use some of this grant applying for a grant. We need to actually have data, and we got ethics approval for that in September 2022. And that was a massive online survey that was done with 166 people over the 9 universities. That's what it looks like. You can see, I've just highlighted Walter Sisulu there as our Eastern Cape, and you can see all the departments were sort of sampled across very many different fields and asked to give their opinions on WBA. I'm not going to give all the results of the situational analysis, but I wanted to look at what the barriers that was identified and some of the enablers that was noticed. So South Africa is not the same as the global north, and it's very good that we look at our own way of doing WBA and not simply adapt what's been happening overseas. One of the biggest issues first is the technology. So I think globally, they're already much better at using ePortfolios and using online forms. I think we are getting there in South Africa. There's a big worry around organizational culture, and you are now subjecting these registrars to regular interactions with supervisors. And for me also, this is more of an opportunity. We certainly need to be shifting organizational culture if there's not a culture at the moment that creates a safe space for that feedback. We've identified the fact that there's very much a lack of training on training. So most of us have not necessarily been through trainings on feedback or trainings. There's a concern about lack of resources and infrastructure, and that includes a lack of the number of supervisors we have around, a lack of time within our clinics. We're providing massive amounts of clinical care, and now you have to try and fit in all these work-based assessments. Standardization also always came up, so we mentioned that earlier. What's interesting is some of the challenges are also some of the things that then came up in the enablers. So what we do have in South Africa is a very strong regulatory environment. So the universities, as well as the colleges, together with their interaction with the HBCSA, has actually got a very strong environment for creating the structure we will need for competency-based medical education. We are certainly moving into an era where everybody is getting more tech savvy, and there's, especially with the younger people, there's a lot more technology out there. So we're actually in an era where technology has become very agile, especially with a smartphone in every pocket. I think the one thing that lots of people have realized is that WBA is already happening. So we are teaching registrars all the time. We're hopefully giving feedback to our registrars all the time. There's amazing opportunities in terms of what our patients are coming across, in terms of learning moments during the day, especially with the kinds of patients that we are seeing. And actually that gives us an amazing opportunity for our registrars to learn on the job. We also actually found that there was a lot of educators and registrars who are actually very enthusiastic about this idea. They like the idea of formalizing this feedback process, and people who have had many, many years of experience in the field of training registrars. And as I've mentioned earlier, we can say we're worried about standardization in terms of individual courses, but actually having these central EPAs, the central vision of what a particular profession is like, is actually very, very enabling. And I think most importantly is that this gives us an opportunity to actually now train our supervisors. We've said we have to train, we have to have good feedback from supervisors, and actually this we've identified as a need in the country anyway, that if you're supervising registrars, you probably should have some training on supervising. So I've got a last few slides. I'm looking at time. I'm probably going to take another 5 minutes or so. Where I just want to tell you briefly about the WUSU Opwork study. So this is a national multi-center study where we're looking at WBA practices, and we basically want to identify the acceptability and feasibility of WBA. So at the moment, we're not yet at the implementation phase, really. We're more in the sandbox phase of all of this. And you'll see that as well. We are exploring experiences, perceptions, concerns, and aspirations. We're looking at acceptability and feasibility. And we're trying to get a realist view of this implementation of WBA. So we're doing a little bit of a sandbox exercise at the moment. And we're doing it by looking at all the universities. So it's a multiple postgraduate medical training units are going to be involved. We've got 29 disciplines at least involved, over 10 different institutions. And we're going to, and so bringing it to Eastern Cape, in the Eastern Cape at Walter Sisulu, we've allocated 3 pilot sites as part of those 29 disciplines. So we've identified family medicine, anesthetics, and obstetrics and gynecology, and it looks like pediatric surgery is also keen and interested to get involved. I'm the principal investigator of this here, but we're going to actually have investigators from all these different departments to be involved with this study. So all that's happening at the moment is we're actually doing training workshops. And actually what I'm doing tonight is actually part of that. We are letting everybody know what WBA is. And then we're going to be doing specific trainings and mentoring here at Walter Sisulu University on these work-based observations. And then there'll be some focus groups and semi-structured interviews with registrars and consultants to find out what that experience has been like. So we've got a team. We always, the more the merrier. So if anybody wants to get on board, please just get in touch with me. And we've just got our ethics approval last week, and we got our provincial approval today. So we are ready to go ahead. So to finish off, I would like to have a couple of slides, just a little educational bit on feedback. And there's a lot of evidence in terms of the power of effective feedback. And I think probably the biggest reason why we should be doing work-based observations is because feedback is actually the engine of training. So it's been shown that it improves students' performance, it improves their, it has a very positive impact on their learning and also on their work performance, and it also improves work satisfaction for the actual registrars in the ward. And I'm sure you're all aware of the Kolb cycle in terms of how we learn. And we know this. We know that the way our registrars learn is by doing something and the consultant observing what they're doing, then reflecting on what has happened. Oh, gosh, okay, I did that, but I really struggled with this. The consultant giving feedback on what they've observed, and the registrar then doing it differently in the future. And I think the important thing is that you don't learn unless there's reflection and feedback happening. Simply having a registrar working in your department and doing the job is not going to turn them into a competent consultant. And without actually building that feedback in, we're not going to create highly competent registrars. So I'll very briefly run through this. I don't want to spend time on it because this is a whole training in its own right. But we've realized if we want to shift feedback, we've got to shift the feedback culture. And I think there's a lot of amazing consultants and supervisors doing amazing stuff on an individual level, but I think we've sort of inherited a feedback culture that can be quite ingrained. And there's these particular sort of underlying false beliefs. The idea that you should already know that, you know, your interns arrive in your department, you're like, oh, for goodness sake, what have they not taught you that? This idea that you can teach through humiliation by putting people on the spot and tut-tutting when they don't know something. There's that Navy SEAL imperative, you know, you dump them into like the most dangerous situations ever so that they can cope in dangerous situations. The idea that we tell them something and then they'll know it. The idea that you only learn from people at the top of the hierarchy, and there's the clever people at the top and the people at the bottom that doesn't know. And there's very much a fixed mindset that some people are good at stuff and some people are not good at stuff. And not an idea that actually anybody can learn something. So what we're trying to replace this with is some aspirations to replace that. So that very culture, which we all say, but not always practice. So there's no such thing as a stupid question. Motivating our registrars through affirming their contribution and what they do well, rather than focusing on what they can't do. Preparing our registrars before you scare or you terrify them. Helping them learn through reflection and feedback rather than through instruction. Knowing that you can learn anything from anybody, no matter where they are in the hierarchy, and this growth mindset. Anybody can learn something. It just needs the right preparation. So for effective feedback, we need to create these relationships of trust, and this needs to be taught. And so I want you to look out for, there will be feedback trainings at the ASAI conference next month. And the dream is that we will eventually have the standardized accredited certification for supervisors, so that everybody can do like a little certificate, a bit like getting your ATLS. You will get your supervisor certificate if you are mentoring registrars. I'm not going to cover the 1-minute preceptor. I want you to feel free to go and look it up. These are 7 little steps you can do when somebody's presenting a case to you. And that's quite fun to have as one of the techniques you can teach your supervisors in how to give feedback if a registrar, for example, is presenting a case. And then you just record that in your entrustment decision. So to finish up, what's happening at the moment is that your respective colleges are busy writing EPAs for your particular discipline. Each department at WUSU will determine its own milestones. So no matter which university department, or for those of you in the future, physios, nurses, etc., you're going to create your own EPAs eventually and create your own milestones for your training organizations. You're going to work with your particular college to develop and pilot some observation tools like the one that I showed you earlier. We need to train our supervisors on how to give feedback when they do those little observations. And there's going to be a little bit of feasibility and acceptability focus groups this year to find out how that all feels. There's a lot of ePortfolios that's busy being piloted by the colleges and the clinical. We're looking at various different things, but in the end, I think there'll be a standardized tool that we will use across all the universities and colleges and departments in terms of capturing all this information. WUSU, as Walter Sisulu University, each department, so Ops and Gynae, family medicine, anesthetics, etc., we will have our own little internal local clinical competency committees to help watch our registrars over time. And then each college will now constitute their own national clinic competency committee to be able to make those entrustment decisions at the end of the 4 years. Thank you very much for listening. Those are some of my other investigators that's running the OpWorks, and I've used quite a few of their slides, so just in terms of attribution. Great, so I'd like to open it now for comments, questions, and discussion.
Dr. Miller, thank you very much. Very informative and very detailed and very, very stimulating. Thank you very much. Colleagues in the chat, you are welcome to put any questions, or alternatively, we've got 51 members in the room, so you can also put up your hand, and then we can, Dr. Miller, we can monitor that if in order with you. And also there's a feedback on the screen. If you can please just help us to also assess the presentation tonight. Any questions from anyone to Dr. Miller, or any comments?
I think it's the kind of thing people are going to cogitate over.
Can I ask a question, please?
Please go ahead to introduce yourself.
Yeah, my name is Dr. Mkocha from Walter Sisulu Nelson Mandela Drive campus.
Yes.
I like the talk. I would have liked you to have a bit of a word about the proportion between supervisor and the registrar population in order to effect the kind of close supervision that's needed. I know that it will be different from different facilities and different causes and different EPAs that you want to assess. And of course, in the departments, also the competences of assessment of the skills of the registrars differ. So what are the proportions of the registrar to consultants in each of the disciplines, if that can be given as a template?
Thank you. So that's a very valid question. And I think that's one of the things we need to look at. We can't adopt what's happening in the global north. And so the phase we are at now, because we are not going to suddenly be able to magically make a whole bunch of supervisors appear. So if we want to make WBA work, we have to make WBA work with how we are structured at the moment. So it's not about trying to find an ideal number. We have to look at, in the way the working life is working at the moment, can we implement WBA and what will that look like? So there was a very nice study recently done in KZN by the surgical team at KZN, where they were looking at, they did a study with the 12 supervisors and 12 registrars that they interviewed for that particular study, looking at implementing one of these tools. So they had one of those observation tools, and they were trying to figure out how much time does it take and how much extra burden does it put on the actual department. So can we build in these observations into our current way of working? And it's amazing to see actually how quick and simple the tool was. It took less than 5 minutes to fill in. And the experience that most of the supervisors and registrars had was actually, no, it's not adding too much extra burden on their day. You have to get your tech right, and that all of them found it extremely beneficial and helpful in terms of the training process. So what we're trying to look at is, how do we do WBA with the way with what we have, rather than chasing what's happening in the global north? Because in the rest of the world, they have extraordinary, as you say, in terms of coverage. And the idea is not that you're suddenly going to watch your supervisor, your registrar all the time, but you need to make sure that there are opportunities where, for example, we've had to now ensure that our registrars at least present to us 1 or 2 patients a week, at least to one of the consultants, which is doable. And then every one of those, we make sure that we then record the particular entrustment decision on that discussion on that particular topic. And that's quite good for us, because otherwise you sometimes forget about your registrars and they become workhorses, and all they do all day is just making the clinic run. And then you get to the end of the 4 years and you wonder why they're not quite ready. So I think it's more about a little bit of a paradigm and a culture shift in how do we build this into our current working conditions. What will happen is, with this feasibility, so I mentioned the qualitative part of the op work study, but it's also going to have surveys, and they're also going to look in depth at exactly that. What is our current ratios? How does the different departments look? And therefore, what are their different experiences about WBA? So watch this space.
Thank you.
First, from Christine Simon asking, will we be able to get a talk, please? Just
yes,
to say that if you want to respond, please.
Yes, so it will be recorded and on our brand new YouTube channel. So the Eastern Cape chapter for SAI has got its own YouTube channel now, so we'll be loading it up there. And then I can put a link in there for the PowerPoint as well, and we can also email the PowerPoint to everybody that's attended, or everybody that's actually registered. I see also there's a question here about how long it will take. So again, we're ignoring what's happening overseas. I can tell you what's happening in practice, and that's what we're learning at the moment. So for example, in family medicine, so it was 2022 when the decision was made by the colleges to do this, and we did the situational analysis. So I think about late 2022, family medicine was already in a bit of a process, but that's when we really got our teeth in to develop our EPAs. And we got our final 22 EPAs together in July of last year. I know the pediatric surgeons are giving them 3 or 4 months to write all their EPAs. The obstetricians, I think it also take it 8 months to a year to get your EPAs together. Every college will be slightly different. What's happening this year is that those of us with EPAs are now playing with the observation tools So again, this is not going to influence my final exams for my registrars for quite some time, and for at least 2 or 3 years, it'll be running parallel. So I've got second-year registrars at the moment, and I think the idea is that by the time they qualify, we're hoping that the EPAs will be an integrated part of their training. I know by 2025, so by next year, we're hoping to actually have a guideline out for the different colleges in terms of getting it done. So again, I think the feasibility and acceptability study we're doing at the moment will give us much better frameworks and also information from the different colleges in terms of where they're all at. But we're actually already in the middle of that process. So this is not a vision far in the future. This is something where we are actually already busy implementing. We have noticed that the surgical departments are way ahead from the more medical fields. And I think the biggest reason for that is that it makes so much sense from a procedure point of view. I think in the surgical professions, it's always been an issue, this thing of having a final exam and you saying somebody is a surgeon, and yet if they're a surgeon, you need to be able to sign off that they are competent in every single one of the surgical procedures you expect a surgeon to be able to do. And it's only work-based observations that's actually going to make that possible. So I think partly the surgical guys are going much quicker because of the motivation. So if you're very motivated, you can actually achieve wonders.
The YouTube channel, we're going to post a link also on the SAI website on the Eastern Cape chapter, ne?
Yes.
Yes.
Yes, definitely, yes. So yeah, it will be available everywhere.
and it will take just give us a few days, then we will put it up. So say by hopefully by early next week, it should be available on the website.
Yes, and please feel free to share this with colleagues as much as possible. Also your registrars, we want the young people to know what's happening and to get involved. We have found the registrars are very enthusiastic about this. I think it's very nice to have a roadmap in this is how I'm going to become a consultant. So it helps them to understand what is expected of them by the end of it. And it gives us a little bit of a structure to help them actually get there.
Any further comments or questions to Dr. Miller?
Right, thank you for the... Oh, there we go. So there's when your registrar presents a clinical case, under which tool do you give feedback and allocate an entrustment decision? So there's so Sonia, in family medicine, under the scoring on ePortfolio, there's a new tool called the entrustment-based decision. And that's the tool we use. So it's a great tool where and then the idea with the entrustment-based decision is when they do a case discussion like that, for you to be able to make an entrustment decision on that person, you do need to ask a few extra questions, like the example I gave with the drug-induced liver injury. So you want to be able to see, how well does the registrar understand this particular case that he's presenting? And then on that information, by asking questions relatively in terms of what would you do if this patient had chronic kidney disease? Well, what will you do if he had a reaction to INH, for example? You can judge a little bit on where their level is. And then you might say to him, okay, I'm going to give you a level 3 entrustment. And then your action plan might be you need to go and read the new Delhi guidelines that's just come out. So it gives them a very nice a way to help them grow in that particular topic. And I think actually that's the tool we should be using the most. It's very, very easy. Also, that tool that I showed you, I'm very happy to also send that round. We really there's no intellectual property here. We want people to use and experiment with tools in their own settings, and then eventually we will each department needs to find something that really works well in their setting.
Thank you very much. If there are no further questions or comments, I want to ask Dr. Rian van der Venter to say the final word of thank you to Dr. Miller, and then also Rian, maybe just a 1-minute teaser or advertisement of the next webinar that are in the planning, and then a final word from me. Colleagues, thank you very much for attending tonight, and Dr. Miller, thank you for an excellent presentation. Dr. van der Venter, over to you. Thank you, colleagues.
Hello, colleagues. Thank you for attending and helping make the first webinar a success of the Eastern Cape chapter. We are testing the waters with what can work and what may not work so well. So we would appreciate any feedback. So our next webinar, as you heard, is about game-based learning. And the idea is just to share experiences of how some of the colleagues have implemented some game-based learning for either teaching purposes or assessment purposes, whether it's summative or formative. So it's more of a scholarship of learning and teaching type of approach to share some experiences of other colleagues based on that. And the idea is to have colleagues from different professions share some of the ideas. Thank you for coming and have a good evening.